So we've spliced the brain up this morning, and now it's good there are two kidneys because we have two nephrologists. So I'm going to introduce both Tonya and Murray. That's as humorous as I get. I'm going to introduce both Tonya and Murray now, and they're going to tag team. It's really great to have both a paediatric nephrologist and an adult nephrologist come along. So Tonya, who's our paediatric nephrologist, trained in the UK and now works at Starship Children's Hospital, but that's part of a service that fantastically covers all of New Zealand. Her interest in TSC was sparked from meeting a couple of families, both from Wellington, and realising how fragmented the service in New Zealand is. I met Tonya earlier this year in Sydney when she came to visit Sean Kennedy, who is the nephrologist associated with our clinics in Sydney. And I was so encouraged to see her passion for making improvements in the care for people with TSC in New Zealand. She's been so helpful in organising this meeting, and I didn't say this in front of your lovely colleagues earlier, but has been dobbing them in a little bit, so thank you. Thank you for doing that. It's made my job a lot easier, and as you've seen today, we picked some good ones. Hopefully they keep up the standard tomorrow. Now I get to introduce Murray. So Murray went to medical school in Auckland. He also worked there, or here, for the last couple of years, for his first couple of years. Specialised in renal medicine, doing his training in Wellington and in Melbourne. He's been back to Wellington for the past 9 years, where he's currently the clinical leader of the renal service. Tonya's told me to emphasise that he's the chair of the National Renal Advisory Board to the Ministry of Health, which Tonya sits on as well. His lackey. So we've got the right nephrologist in the room. His interest in tuberous sclerosis started on a personal level when his daughter Libby was diagnosed with TSC. And I added on to his bio that this has him join the ranks of a number of amazing renal physicians around the world that have a similar reason for their passion with TSC. It's a bit of a funny thing. There's a few of them around the world. There's a urologist in the States, that's it, with a U, not an N, as well as Chris Kingswood in the UK that have a similar situation. Murray has subsequently taken a special interest in those patients who come through his service with kidneys affected by tuberous sclerosis. I'll hand over to you guys. Thank you so much.
And so with what happens to kidneys in tuberous sclerosis complex? Well, there's a number of things that happen, and Murray's going to talk a bit more about some of the specifics of these later on, because I know you're all going to be dying to ask about mTORs and everolimus. But essentially, within that normal tissue of the kidney that does the work to clean the blood, you get fluid-filled spaces called cysts. And these, if you have a look at your children's ultrasound scans, if your children are indeed having ultrasound scans done, which I'll come to later, those are the black holes inside the ultrasound scan. So it's fluid-filled holes that they're not taking over the normal tissue of the kidney, but they're kind of pushing the normal tissue of the kidney to one side. There are a common type of cysts, which are called epithelial cysts. Epithelial means skin, and they're not harmful. And there are polycystic cysts, which, again, Murray's going to talk about a bit more later. They're much less common, and they're much more significant. The AMLs, which again you may all have heard about, they're the big white things inside the kidney, and again it's tissue that's kind of pushing aside the normal tissue of the kidney. So essentially that means in most children the kidneys are working normally despite these things happening inside there, and so these don't actually interfere with the function of the kidney, the thing that's meant to be checked every year. The kidneys will carry on working and cleaning the blood normally. But there's growing recognition of early onset of hypertension, and a lot of that work has been done by Sean Kennedy, who Claire alluded to, because getting blood pressures checked is not an easy thing in children. As you may know, it's not just actually doing the blood pressure on a small child, it's actually having the equipment there to do it. Not every clinic will have it, definitely not every GP will have it, and not every paediatric clinic will have it as well. So it's very easy to write off a high blood pressure as being because that's what's just happened on the day and put it off, but actually when you're in a specialist clinic, having the blood pressure measured properly, people are recognising these children get hypertension. One theory for this is that there's a hormone that the kidney produces that pushes your blood pressure up. And when those kidneys are under pressure, even though the tissue of the kidney is working properly, that tissue starts to get a bit stressed and it pumps out this hormone more and puts your blood pressure up. And so one of the things I've been a bit interested in is trying to find out if there are protocols looking at measuring blood pressure outside a clinic setting in children with TSC, which I haven't been able to find yet, and I'll talk a little bit more about later, but that's the ABPM I talk about there. And as I said, the kidneys are kind of a hidden thing. There's no real external signs of kidney disease. It's not like when your liver goes wrong, you go yellow. If your heart isn't working properly, see children, they talk about them going blue, but they kind of look a bit purple. Kidneys, basically, you look absolutely normal on the outside, really right until the end. So our children with what we call end-stage kidney failure, when they come in needing dialysis or a kidney transplant, may have been at school, they may have been a bit tired, they may not have been growing well, but they can come in on the point of really heart failure because their body's been so tired without any real external sign that people can pick up. And those are the kids whose kidneys aren't working properly. Your kids' kidneys almost definitely are working properly, so there's very little that you can do to look from the outside. So it really does require people to follow those consensus guidelines and do the imaging. High blood pressure, again, is the exception for this. And if you've got really significantly high blood pressure, you'll get headaches, visual disturbance. But again, I think the group of children with TSC, it's not dramatically high blood pressure that will get picked up easily. These children are sitting just at the top of normal or just above the top of normal. So people write it off and maybe check it again in a year and it's still up there and they're not really looking at it. But that's probably enough to... Again, just to add that onto that background of children who've already got trouble with school, who may be a little bit more tipped over into their seizures, that may just be something that if it gets checked a bit more and looked at a bit more, might just be one of those things in the background for your children that could just make things a little bit better for them. So what can we look for as nephrologists and as paediatricians? Well, there's consensus guidelines, which as far as I could work out, have been available since 1999, and they're updated in 2012. And I'm sure you've all seen the copies inside your booklet. And you might also notice it was published in Paediatric Neurology Journal. It is available on open access, but that's not a journal that people in general paediatrics are necessarily going to be reading on a day-to-day basis. And this is the recommendation, and this is my view of it. And this is one of the, sorry. Can I just say that we tried to get it published in the Lancet, I think, but it was not fair. Yeah. So, yeah, everything. So, yeah, So, yeah, and then when you come into things like my subspecialty view, I'll look at that table, and all I'm going to look at is the kidney bit because I'm a subspecialist. And I think there's a real issue with people looking at your children more globally, as in multidisciplinary clinics, and looking beyond your part of the guideline. And I think some of that, I'll talk a bit more about that later, but I've got a couple of ideas about that. So are these guidelines being followed? I'll just go back to them quickly. The MRI of the abdomen to assess the presence of AMLs and renal cysts, that came in 2012, so there's not really been time to see whether people do that yet. Screening for hypertension by obtaining an accurate blood pressure. Well, for me, working in paediatric nephrology, the only way to get an accurate blood pressure is actually to do it outside the clinic with ambulatory monitoring, which is wearing a cuff for 24 hours and having a recording done. I don't think you ever get an accurate blood pressure for a stressed child, which is every child potentially coming to an outpatient clinic who may have had a blood test, who's probably had imaging, and you may not be able to explain what's going on to. So for me, that actually, I would suggest that meant we should be advocating a bit more for ambulatory blood pressure monitoring. And it's evaluating renal function by determination of GFR. GFR is a measure of how well that blood going through your kidneys is cleaned. So if your kidneys are working at 100%, your GFR is 100, which is the top end of 100 to 120 is normal. Anything below 80 would probably hit one of our clinics. But if you have a blood test done, if you look at, if you see them printed out on a screen and it's the normal ranges, normal range for paediatrics comes up as something like 20 to 70 for a blood test called creatinine. And creatinine of 20 in a 2-year-old will be as black as the creatinine of 70 in a 2-year-old, because it's all within that range. They don't differentiate in blood test ranges between the child who's being measured. So that could be a 10-kilogram child or a 90-kilogram child, or seeing as we're in South Auckland, an 130-kilogram child, and we don't know. So really, actually, if you're going to follow that properly, you'd look at a more three-dimensional way of doing it. But at the very least, you need to have there needs to be somebody thinking, how big is this child? at least trying the equations for changing that into a GFR and not just a creatinine. Creatinine, if you like, is a line on a piece of paper. It's a one-dimensional measure of a child, and if you're going to do a measurement of GFR, that's more like a three-dimensional thing. And there are ways of doing it just with that test by looking at their height and their age and things like that. But again, just encouraging people to think a bit more beyond that. So are these guidelines being followed? Well, this is a paper that was published by the group, by yourself and by Sean's group. So you probably might be able to add to this, Dave, before me. But I thought I'd look at, knowing how the guidelines are being followed in New Zealand, I thought we'd look at what's probably the best example of care for children within the region, which is the multidisciplinary clinic in Sydney. And the patients are referred there for a multidisciplinary clinic, which is all over the region. And these were the recommendations at that time, which from a renal point of view, because I'm very skewed, as you know, is getting the ultrasound done. And they found these are patients arriving in the clinic. They're not patients who are being followed in the clinic. But I guess just the fact that they're arriving there probably means that they've got a more than interested paediatrician and more than committed parents. And majority of children were meeting surveillance guidelines, but very few of the adults were. And they commented on a better need for transition into adult care, which I think Colette's talking a bit more about tomorrow. And certainly, we find for children with quite common renal conditions that it can be quite hard to work out their progress into adult care. And I'm quite lucky that I go to Wellington, where Murray works as well, and we actually have people from adult services coming to the clinics there, so it's a very smooth way to help somebody go from a paediatric model of care to an adult model of care, because we actually see them all in the same room together for years. But I think seeing this, it just made me wonder, when I know how the guidelines are and aren't being followed in New Zealand, what happens to the adults here? And blood pressure isn't measured on that, and I moved my slides around a bit and forgot I told Murray that I'd done that because he put the talk together for us properly. But just coming back to blood pressure again, it's my hobby horse, if you like, and Claire and Melinda are talking about surgery being their passion. And epilepsy surgery, I guess, is the pinnacle of epilepsy care for them. Blood pressure for me is it's the bread and butter for nephrology, and it's because it's so treatable. And it's so harmful if it's not picked up. And, you know, you're in a clinic, you're not getting time for blood pressures to be done. And actually, if you look, how I talked about the creatinine, the blood test look for kidney function, how you have to look at that in relation to the child's age and their size. It's the same with blood pressure. So you look are they a boy, are they a girl, how tall are they, how big are they? There are 964 measurements on one table for paediatrics to look to see if a blood pressure is normal for a child. Nobody looks, they just write normal, unless it's so abnormal that they have to notice. So in New Zealand, I think we're only seeing a very small number of children in the paediatric nephrology clinics, so our experience may not be typical. The vast majority have had no renal imaging for years. I haven't seen any child yet who's been referred who's having an ultrasound even 1 to 3 yearly, and none of them have had a blood pressure done. So the consequences for us are, it's very easy to try to distinguish between the type of cysts that I don't need to worry about, they're common in TS, and the cysts that are more significant because they can lead to high blood pressure and to progressive deterioration in your kidney function in adulthood. It's very easy when they've been ultrasounded from the start, but when you have patients turning up and their last ultrasound was 10 years ago, or their first ultrasound was when they're 15, it's very hard for a radiologist not to write these maybe polycystic cysts on there. And then we have to go down a whole path of trying to work that out because there are implications for the child and for the family. And so following the consensus guideline on that would be great from our point of view. It's very hard when you're faced with an AML for the first time to know what the rate of growth is. Again, saw somebody who had had 10 MRIs of their head and spine, and then incidentally somebody had noticed something hanging off the edge of one kidney. And they had a 10 centimetre AML, and you don't know the rate of growth, you don't know whether to say, they're saying, what do? You don't know how fast it's growing, you don't know whether to recommend that they should be getting the biopsy, you don't know the rate of growth or anything. And The other issue that we're seeing as well is a lot of places are reporting, because if you've got lots of AMLs together, it can look like cysts, and if you've got lots of tiny cysts together, it can look like AMLs. So again, people following the consensus guidelines would be great. It'd be lovely if you all put your hands up at the end of this and said, oh no, all our children are having a scan, they're all fine. But certainly all the patients that we're having referred in, unless they've got families who are going in with the guidelines, they're not getting scanned at all. And as I say, missed hypertension, it's an easily treatable condition. So on the plus side, before I hand over to Murray, and here we'll talk about the mTORs that I'm sure you're all dying to hear about, radiology departments at Starship and Wellington have been extremely amenable to adding an abdominal MRI onto any cranial MRI. And they have actually contacted me about a couple of patients going, we've been asked to do this for TS, did you need them? Do you know about them? And then, so because I know there's an issue in Australia that with funding through Medicare to get this done, for us it's just time availability and people actually asking for it. So I've managed to get this through for several children this year. One of the other things that's happening here is the Health and Disability Commissioner has got a thing about health passports with patient needs on there. Now, we use health passports a lot for our transplant patients. You have lists of, you last had your screening for this virus at this time, you are next due at this time. So we have it in a computer system, but often the parents will just say, oh, do you know their last hand bone age was, X months ago? It would be very easy to put these imaging guidelines into a single-page sheet that you could just plunk in front of your paediatrician and go, look, the last time I had an ultrasound was 2 years ago. Do you mind very much just requesting one? And it used to be very easy. New Zealand is a long way ahead of some countries, and we use a lot of electronic records here. It used to be you had a patient, paper file, open it up, clip the consensus guidelines in there, and every time you saw that patient in clinic, you just flick and look. But everything's electronic now. You need to have electronic reminders because that sheet that you put into the patient's notes when you saw them gets scanned into a computer and it disappears. So there are national guidelines where you could have links to your consensus guidelines, and one of them is the Starship clinical guideline. And there are plenty of links on there for recommended reading and things like that. And I'd be very happy if you want me to suggest that, to just tell Greg to put it on there because he's in the office next to me, which makes it very easy. And I will now hand over to Murray for the more scientific part of the talk.
Is this on now? Yes, don't underestimate people doing what Tonya tells them to do. She's very persuasive, and I'm here thanks to Tonya. So I'm an adult nephrologist, but I do know a thing or two about children. I've got, or had 3 of them. And this is Libby, who's my eldest. So she was diagnosed at age 4 months of age with TS. And I must admit, I was thinking earlier this morning, hearing some of the stories, I should have stood up at the beginning and said, it's a bit like AA, hello, my name's Murray, and I'm a parent of a TS child. Because I could rattle off every one of the symptoms and signs and descriptions that you've all been through as well. 4 months of age, spasms. We didn't recognise what they were, and I'm a doctor. Looking at your child sitting there going, and you go, well, that's a bit odd. So you get your wife to ring Plunkett line, and they go, well, that's a bit odd, but it's probably okay. And then a week or so later, when you've seen 10 of them, you think, no, that's not right, and you go to the hospital. We didn't need an MRI. Our paediatrician was very... I won't even put a word to it. Had a medical student in the room, and he looks at Libby and examined her, and of course she had the char-green patches, the confetti spots, the white spots everywhere else. And he looks at her and he goes to the med student, oh, fits, zits and nitwits. So fits, we all know about those. Zits because of the facial rash, and nitwits because people often have intellectual troubles. And I'm sitting there going, oh, okay, yeah, I remember that from medical school. And so TS was diagnosed, and of course Libby's been in every paediatric exam since because she's got all the classical signs. So we've been through that, and people talking about anti-epileptics, or we went through 7 of them. I think 7 different types, including topiramate I heard before, where Libby lost her speech on that one as a side effect temporarily. Before, at the age of 2, we eventually got to Melbourne and had surgery to remove a tuber that was causing her seizures. And of course, I don't know, you've all probably got the little booklet at home with your own little notebook. We write down every seizure and the time and the number per day. So we went from our 10 or 20 a day down to 0 from that surgery, which is fantastic. But of course, from that surgery, you then get grand mal seizures that occur every couple of months after that. But they fizzled out after a couple of years, and we were told that was just a consequence of the surgery. And so from 7 drugs at various times down to none since the age of 4, and she remains off all anti-epileptics, which is fantastic. But of course, neurological problems, behavioural issues from time to time, although it's difficult to know. She's 16 now, and she's a teenager. So like someone else said, I don't know what's going on half the time. And I'm a bit stressed out now because there's a boyfriend on the internet, and so I don't know if that's TS or not, but that's new for me. Yeah, we've done that. We've had a Seeger, and David was saying before that no one should ever get hydrocephalus these days. Well, we've been there, we've had hydrocephalus. We've now got a shunt in, and it's hidden under that mop of hair there somewhere, along with other scars from other surgery. So we got that shunt put in, and that's supposed to resolve hydrocephalus if anyone's been there and done that. But of course those shunts can block, so we've been there and had that and have had the shunt revised. And then you get off to the oncologist who you think will know all about this for the brain tumour and drugs, and they're going, ever what? Ever what? What's that drug? No, never heard of that. That won't do anything. You need surgery to have that Seeger removed. And the neurosurgeon saying, oh yes, we'll whip in there and remove that. And we're going, no, but we can't. And they say, why not? We said, we don't really want to face surgery, because when she was 2, one of the complications of her surgery was that she had a stroke. And so she's disabled on her, I've got to remember now, right side. And so she walks with a limp and a hand up here and everything else. So you go through those things, and someone else said learning difficulties in school. It's a challenge at times. Teachers, some of them are fantastic when you tell them that someone has an auditory processing disorder, because we have been to see a neuropsychologist who identified these things. And the teacher will understand that you can't follow 3 instructions when you only hear 1. And then you go to another teacher and they just treat her like she's like every other kid in the class and think she's disruptive. So you have your challenges. So we've been through that, and we've got the AMLs in there as well. But we are on everolimus, and her angiofibromas have really gone down. So summertime when the face is bright red and just one big rash, now it's really good, but we get acne instead. But that's probably being a teenager. So yeah, I've got a story just like everyone else's. But amongst all that, I'm a nephrologist, and so I see people with kidney diseases, and sometimes one of the challenges is someone with this condition comes into my clinic, and I have to work out whether I tell them I know lots about it or nothing about it, and you have to go with the flow in that conversation. So, kidney disease in TS. So I think about 85% of TS people will get kidney diseases, most likely AMLs. But they can get all sorts of things, and these are the sort of things you'll see listed in books and brochures and things about TS. So you get cystic disease, and as Tonya's mentioned, you can just get ordinary little what we call simple cysts. They're like little blisters on your kidney, absolutely harmless, don't mean a thing. And everybody will get them as they get older, the normal people as well. But TS people can get a few more of those. Usually they don't cause any harm at all. People can get polycystic kidney disease, which is a specific entity, and I'll talk a little bit about that. Blood pressure, as Tonya mentioned, really easy to check in adults. Kids, it's a nightmare. Anxiety, every one of your kids or yourselves may absolutely be petrified at having tests done, including a blood pressure cuff or blood tests, and have to go through whole desensitization processes just in order to get a blood test, which is the only way you can tell what your kidney function's doing. But very, very easy to treat, and any old blood pressure drug will do. So, and when it comes to treating kidney disease in adults, the first, second, and third thing we treat is blood pressure, then blood pressure, then blood pressure, before we worry about anything else. And most of my patients who come into clinic that I see, the only thing I'll touch on the patient is their arm for their blood pressure. I don't examine them any further than that half the time. Kidney stones can be more common. Mentioned that. Kidney cell cancer, fortunately not more common. Maybe just slightly, but really not a big deal. And angiomyolopomas we'll talk about. So polycystic kidney disease is a different condition altogether from TS. But, and which one's the pointer here? This one here. Somewhere on there. That one maybe. one of the genes that's got the TSC2 gene on it, one of your chromosomes, the TSC2 down here, that gene is right next door to the gene for polycystic kidney disease. So some people have a mutation that crosses over both of these genes, so they'll get a combination of TS and polycystic kidney disease. And polycystic kidney disease turns your normal-looking kidneys into a big bunch of grapes, a whole lot of cysts, megacysts, and that's a football there, and your kidneys, which are normally the size of your fist, can grow to the size of a football. So there we go, there's a normal kidney and these things. Enormous things, huge things, make someone look pregnant. And as those cysts grow, they just squash the normal kidney tissue and destroy it, and people end up with kidney failure. So that's another autosomal dominant inherited condition, like TS, but it's got a completely different consequence, which is kidney failure, and those people eventually need dialysis or a transplant. So if you've got a combination of those two things, then that's difficult. So it's something we need to be wary of, but the majority of people, with TS are not going to have it. So only a couple of % of TS patients will have polycystic kidney disease with it. But it's a significant thing when they do have it. So that's polycystic kidney disease. Hypertension. Tonya's mentioned lots of things about this. Control is critical to further decline in renal function. One thing to remember is it can be a side effect of your other treatments, including mTOR inhibitors can cause hypertension. So we have to watch that. Kidney stones, really common in the general population. A few people in the room may have had them who don't have TS. But there's a higher risk of getting stones with drugs such as topiramate or the ketogenic diet due to the way the body handles things that make stones, like calcium and citrate, as it goes into urine. If you've got AMLs, someone who gets a kidney stone will get what we call loin to groin pain. They'll have pain that starts here, goes down to their genitalia, and they double over, they roll around, it's dreadful pain. They say it's like childbirth if you're a man. If you're a woman, they just say it's bad pain. But sometimes a hemorrhage from an AML might give exactly the same pain. So you have to have someone switched on to thinking about different conditions and investigating things. The treatment ordinarily for some stones in people is to give shockwave therapy from the outside to shatter the stone and make it pass. But you don't want to do that when you've got a kidney that's got AMLs in it, because you might rupture those AMLs. Cancer, I'll say it's a rare finding, but possibly a tiny increased risk. The way to treat those is just to remove them. But sometimes the cancers can be hard to tell the difference from an AML on a scan. So you've got to do serial scans, so 1 year, 3 yearly, whatever the plan is, so that you can see and check out how things are growing. And if something's not going to plan, we have to be suspicious of things. Right, so angiomyolipoma, these are the big things in kidney disease. So just to make you understand it all, most of medicine's written in Latin. So angio is because it's made up of blood vessels. So you get a whole little rash of blood vessels occurring inside the tumour. The myo bit is because it's made up of muscle. And this one here is a scan showing a combination of various things in it, but there's muscle cells made up in it. And the lipoma means fat. So on this ultrasound scan here, the big white ball there is a ball of fat. So an angiomyolipoma is just telling it's a tumour made up of lots of different things. And if you're going to have successful treatment, it's better if it's got lots of vascular bits in, because they respond to the mTOR inhibitors. So there's lots of different scans we can do. And one of the problems here in New Zealand is it's a cheap country when it comes to healthcare. We don't like spending any money. Don't like referring anybody anywhere. MRIs, they're available everywhere, but you just can't seem to get into them. Long waiting lists. So there's various scans we can do. We can do an ultrasound scan, and that's easy. It's cheap. Doesn't hurt people, but you've got to press on the tummy quite hard sometimes. But you won't see all of the tumours in an ultrasound scan, especially ones that don't have a lot of fat in it, and we won't see very small tumours. The scans just aren't good enough. But it's not a bad screening test for people. So if you're going to get anything in a young child, the easiest thing is probably to get an ultrasound scan. If you've got a great big tumour, you'll see that. So that's one way you can start. We can get CT scans, but they use a dose of radiation. So we don't like doing lots and lots and lots of CT scans on people because that's giving people extra doses of radiation they don't need to have. It's good for most tumours, but again, not good for fat, poor lesions. And that's the important bit if we're trying to distinguish cancers. Or you can do MRI scans, which is probably the best scan, but it's expensive and it's not so available because all the MRI scanners are full of orthopaedic patients with their injuries that they seem to get, or oncology patients with their cancers who get scans every 2 minutes. Anyone here had MRIs? Yeah, it's quite claustrophobic. No, but yeah, you sit in a little tunnel. You get a cage over your head if you're having a head scan. And then all it does is go bang, 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 the noise from it. So you throw someone in there who's got an anxiety issue, behavioural issues, comprehension issues, or someone who's got a programmable shunt-in for their hydrocephalus who says, I can hear it tingling, and the radiologists and everyone's saying, don't be silly, it's not going to make any difference. You can't hear that at all, and your daughter's going, yes, I can, I'm not going in there. So, you know, MRIs are difficult, so you often have to have a general anaesthetic for it. And then that's another whole deal. That's another whole day in hospital as opposed to a scan which will take half an hour. So, yeah, challenging. So AMLs, 80% of TS patients have them. We call them benign tumours. In terms of lumps and bumps in the body, you've got benign and malignant. And traditionally, you think of those as benign ones are just growths that don't cause any harm at all. Malignant ones are like cancers which spread elsewhere. But they're not benign in terms of they can cause problems. They can bleed, which is the biggest issue. They can bleed, and it can lead to kidney failure. So they can get so big and squash so much normal tissue that it can lead to kidney failure. Not very common, though. Right. Majority of people, though, aren't going to have any issues from their AMLs. So we've always got to remember that you know, we're talking about bad stuff, but most people will be okay. And like everything in life that you read in magazines, size matters. All right? So when it comes to AMLs, size matters. If you've got an AML that's less than 3 centimetres, it's not likely to bleed. Not to say it can't, it might bleed, but it's less likely. So ones that are bigger than that are more likely to bleed. When do they occur? We go back to Sydney Children's Hospital with their lovely program and they keep all their stats and things like that. So AMLs are not so common in little kids, but once you start growing through paediatric years, you know, 5 to 10, 10 to 20, much more common. All right. And as people get older, they tend to get bigger, so they do grow a little bit. But you can tell from this picture that, you know, you're going from 0 age up to, say, 40 here, and you're going from, you know, less than 1 centimetre when you're 15 or so up to 3 centimetres or so when you're 30. It's a slow growth, you know, going from 1 centimetre up to 3 centimetres over that time. It's pretty slow growing tumour for the most part. But there's a huge range. Right. So bleeding, when they bleed, they can bleed and bleed like a stuffed pig. Right. If they're bleeding and a patient is compromised, so their blood pressure's low, their blood count's gone so low that their life is at stake, you've got to do something. So we forget all the talk about mTOR inhibitors in this situation. You've got to do life-saving treatment. And that's where embolization, or knocking off the blood flow to that AML, is the first thing we will try and do. So we'll send someone into an X-ray room, an angiogram room. We'll put a special tube into the artery in someone's groin under local anaesthetic, so it's not so sore. Feed that little tube up the arteries inside, into the kidney artery, up through here, and then this one's bleeding off the corner here. We'll feed that tube down there and try to squirt some stuff. Doesn't matter what the stuff is, sometimes some little wire tube, sometimes some glue, sometimes some little beads, things that are going to block that artery to stop it bleeding. All right? Silicone, whatever it takes. all right? So that's what you need to do to stop that bleeding. All sounds very easy, but you've got to have someone who's pretty good at doing this. Because sometimes it could be one tiny little vessel that's bleeding and not half the kidney that's bleeding. You don't want to knock off half the kidney if there's only one little tiny spot. You want to preserve as much of your healthy tissue as you can in the kidneys. So it's done for acute bleeding embolization, and sometimes we use ethanol to do it. Sometimes ethanol plus oil, PVA. Coils, foam, there's all sorts of agents you can use. As long as it's inert, so it means the body's not going to react to it, and it's not going to be able to move outside that blood vessel. So one of the questions is, do we do this for people who are not bleeding? So if you've got a kidney tumour, an AML, that's bigger than like 4 centimetres, should we just go in and embolize that and take away the risk of bleeding? I don't know the answer to that, because there's no, in medicine we look for clinical trials to know whether it's worthwhile doing or not. We don't have anything to say that, well, this group were embolized and this one weren't, they did this and they did that, and compared the two groups. We don't have that sort of information. But some centres will embolize large tumours before they bleed. It's not to say it's wrong, it's not to say it's right either. And they do that because maybe half of them are going to bleed if they're over 4 centimetres. And there's a study out there, I can't remember which one it was, showing that over a long period of time, tumours over 4 centimetres will bleed about every 3.5 years. So there's a risk of bleeding there. Sometimes you can have a little aneurysm or a little outpouching on the blood vessel. That's an even higher risk of bleeding, so people will close those off with embolization. And one of the troubles with embolization, when you kill off some tissue inside, and that tissue then has to die, you get a reaction. The body doesn't like that. You get pain, you feel sick, you might vomit, you get a fever, you get a whole lot of inflammation reacted to that. So if you're doing it, people need to give some steroids at the same time, and that might be intravenous steroid through a drip, followed by some tablets for a couple of weeks. And the regime that's sort of talked about in the medical journals is one that goes back probably about 20 years now, and people haven't come up with a different regime, and I've written it on the slide here. But a lot of radiologists or urologists, are the kidney plumbers, are the surgeons who deal with kidney stuff, they don't know this stuff. And so people like yourselves, other parents, are the ones who have to go in saying, oh, you know, or patients saying, you know, if you're going to do that, I want some steroids. And they're going, don't be stupid. But you guys know best, all right? Because these people might only deal with this once every couple of years. So try to preserve as much normal kidney. If the embolization doesn't work, they may need surgery to stop that bleeding. You know, open up and go inside and actually put a stitch through that thing and tie it off. All right? What you really want to do is tell people, don't take my kidney out. Because once you've removed that kidney, you're not going to get it back again. And then you've lost half of your kidney function. You've immediately cut your kidney reserve, if you like, down by half. And guess what? You've still got AMLs in the other kidney. If they go and bleed and someone says, I'll whip that one out, then no kidney function, another whole ball game needing dialysis or a kidney transplant. So you want to do what we would call minimally invasive surgery. If someone has to do surgery, just operate on that little bit of the kidney that's bleeding and don't just go and whip the whole thing out, because a lot of the kidney will look abnormal with multiple tumours throughout. But they should be able to see which bit's bleeding and just deal with that bit. So got to tell them, just wait and pause, go and read the medical journals before they operate. Have a cup of tea first. Yeah. So do these AMLs grow? Well, they grow really slowly. And one of the things is, if you do serial scans, if you're getting more than about 0.5 centimetre growth in 1 year, then we might be suspicious that it's something a bit more sinister, like a cancer. It's a bit of an arbitrary figure, but that's the numbers that are out there in the medical literature. So Libby's got a nice, healthy brother who sits beside her sometimes and treats her well, and other times they rack each other up, just like every other good teenager. So that's the acute stuff, but long term, what do we do about these things? And lots of talk about these mTOR inhibitors. Well, yes, in kidneys, it's the same story. So sirolimus was the first of the mTOR inhibitors, and the only reason that it's not being funded for treatment is that Novartis came along with everolimus and did a proper clinical trial that all the authorities listened to, and the people who make sirolimus didn't do that, so everolimus gets funded, not sirolimus, but it probably does the same stuff. So this is one of the early studies looking at sirolimus, an mTOR inhibitor, in AMLs. And there's study protocols they all went through, but it wasn't a proper trial. It's really just an observation of what was happening. A whole lot of people, they started here with the size of their angiomylopomas, and they went 12 months on the sirolimus, and hey presto, all their AMLs shrank down in all the patients. And then they took them off the drug and measured them again, and by another 12 months, some of them stayed small, but some of them grew back to the size they were at the beginning. So that adds to that whole question of we don't know how long to treat people for yet, be it kidneys or be it brain or lungs or whatever face we're treating. We don't know how long for. If we stop the treatment, things may grow back to where they were before. This is just a picture showing the sort of things they were seeing. So it's hard to tell, but we'll say there's a tumour there, and it's gone on that one. There's one there, it's probably a lot harder to see, and it's gone on that one there. Another little one up the top here, and it's gone over there. So that's what they're seeing. Another study doing exactly the same thing. These are called phase 2 studies, which are looking more at safety of a drug and trying to work out doses and things rather than comparing the drug versus no drug. So virtually the same sort of picture. Tumour size went down, came off it went back up again. And more pictures showing the same thing. Big tumour here, 6 centimetres, going down to 3.9 after a year. So, 6 centimetres is a high risk of bleeding, 3.9, still at risk, but less. Going down, same things. So then the big proper trial that was done was the EXIST-2 trial. All right, so EXIST-1, looking at SIGAs. EXIST-2, looking at AMLs principally, but they looked at all sorts of other things in it as well. So this is what we call a phase 3 trial, which means looking at all these things here. Double-blind, placebo-controlled, multi-centre, randomised trial, medical jargon. This is a proper trial. All right? So double-blind means that the people who are giving out the drug and the people who are taking the drug and the people who look at all the results don't know which things people are on. The people are just a number. All right? And then they decode it afterwards so that so people aren't giving a false reading because they think, oh, this person's on the drug. Yeah, I think that one's gone from 6 centimetres to 3 when they're measuring things. Or that person's on the placebo, the sugar pill. Yeah, I think it's only gone from 6 down to 4. You think, oh, that's daft. Why would people think like that? But your mind does funny things when you know what's going on. So double-blind, placebo-controlled, so a sugar pill and everolimus on one side. Multi-centre, because there's never enough patients in one unit. So you've got to get centres from all around the world to contribute patients to these studies. And New Zealand does do clinical trials, not so much, well, we haven't done the TS ones so much, but in lots of other specialties, and in my specialty, we do lots of clinical trials, often part of worldwide trials, and we'll enrol 10 patients to help out a study that needs 1,000 around the world. But it takes a lot of work. If anyone's been involved in medical research, it's a lot of work. And randomised just mean that you didn't get a choice whether you got the drug or not, which is really hard for vocal patient groups because they all want the drug, but none of them want the sugar pill. So that's a hard thing to buy into when you enrol in a trial. You've got to say, okay, well, I could get the sugar pill. But to counter some of that, and because people thought it was going to really work well, for every 1 sugar pill person, they had 2 people getting the drug. Then after the trial's finished, give everyone the drug. So what happened? On the everolimus group, pretty much everybody had a shrink in their tumour. Not quite everybody, 1 or 2 had a growth and things. Right? So these aren't absolutely perfect drugs. And the people who got the sugar pill, a couple of them shrank their tumours anyway. Most stayed about the same and a few grew, so it didn't make any difference overall for them. So this was fantastic. It worked. And because of that trial, the FDA in the States, their drug licensing people approved things. Europe approved it. Australia, New Zealand approved things for use. It's not to say they're going to fund them, but they've licensed it. What about whether these mTOR inhibitors stop people bleeding? We don't know that yet. So in that exists 2, they didn't report on rates of bleeding from the patients. They might have that information, but they haven't published it yet. But it might also be too small to tell. If you've only got 100 people on each side and there's only 2 in each placebo group and 2 on the other side that bled, the numbers are too small to know that it made a difference. So we have to wait and see whether it actually will make a difference to how often people bleed. We know it shrinks the tumours down, but will that stop people bleeding? We don't know yet. So yeah, we know all this information. April 2012, the FDA approved it for TS AMLs, and they approved it at a standard dose, 10 milligrams a day, because that's what the trial had. And 6 months later, in Europe did the same thing. A year later, Australia funded it through their PBS. In New Zealand, it's licensed for use, but you have to go through what's called an NPPA, or named patient pharmaceutical application. So you have to apply specifically, and you've got to show everything else has failed, and this is the last resort type thing. But yeah, for AMLs at least, anyway. SIGA's different now. But you know, despite all your bad stories about how bad people are, there's always people out there worse. This is my daughter running, and she runs an Athletes with Disabilities, and you can tell that her righty hair floats up high when she runs, and when she runs it goes up even higher because she's got no physical control over it. She has effectively cerebral palsy from that. And despite her getting this leg through, she runs with a big limp because that leg doesn't work. And we've shortened that leg because she had a leg length difference, so we shortened a good leg to match things up, so she's a bit of a shrimp. But despite all that, she's the reigning national champion for athletes with disability 100 and 200 metre running. You know, kids can achieve things if they want to, but you know, she's in her own category. She's a bit slower than the able-bodied kids, but no, so specials for the intellectually challenged people. So she's in the physically disabled group, so athletes with disability. She's got a category T37. So that's more the Paralympic stuff as opposed to Special Olympic stuff. Yeah. So we've got all these things of what to do and all these guidelines, of which New Zealand's a bit hopeless at it so far, although admittedly the guidelines, the new ones, only came out in 2012. You know, but now we're saying get an MRI at the time of diagnosis to assess the presence of AMLs, screen for blood pressure, follow up your kidney function with blood tests. MRIs every 1 to 3 years. And when you start that, I guess, is a bit of a question, because you don't need to do it every year for 0 to 5-year-olds if there's no big AMLs there to start with. But you know, an MRI every 1 to 3 years may not be practical for a lot of people. Or if there's no cyst there, you might go down an ultrasound route. So while there's guidelines, it's not to say that's what you have to do for everybody. You might make a choice to do something slightly different. Embolize for bleeding. Don't take kidneys out. mTOR inhibitors will arrive here, exorbitantly expensive. You know, you're talking about 100 grand a year for everolimus at the moment. So that's high cost. And I've put this up because that's our family now. I said I had 3 children before. I did have another son who passed away when he was 4 from an unrelated condition. He had a brain hemorrhage. But it's our little family on holiday. Libby's a few years older now, but she's just done NCA level 1, and touch wood, we've got enough credits. Or as I said to a couple of people earlier, I think my wife has probably got enough credits because she's done a lot of the homework, rewritten a few of the essays. So we'll see. So thank you. Questions? I can see them coming.
For the most enthusiastic question.
Sorry, I was just going to ask, is that that kidney disease what do you call it again? Yeah.
Polycystic kidney disease. Yeah.
Is that treatable?
No, so the AMLs we can treat and shrink down with everolimus and sirolimus and probably temsirolimus and all the other olimuses that will follow. In a lot of people, but not necessarily all of them. The polycystic kidney disease, at the moment, we can't treat. And they will eventually progress. The cysts just get bigger and bigger, and eventually they'll end up with kidney failure, often in 40s to 60 age group. Some earlier, some later. There's been some trials looking at the mTOR inhibitors at them, and they were a bit disappointing. They didn't really show any change in cyst growth. But there's questions about that. They may not have given the right dose. They may not have treated for long enough. This is something that progresses over 50 years. So treating someone for a year, you can't really tell whether it's made a big difference. I keep telling my patients that, I think because it's genetic, I think, look, you've got this and you're going to progress and you're going to need dialysis or transplant. We're going to have to look at your kids at some point because it's inherited, 50% chance. But I'm hoping they're not going to ever have the same situation because new drugs will come along. So at the moment we can't treat it apart from blood pressure for polycystic kidneys, but we're hopeful and something will come along. And I think all this research going on with the mTOR stuff, we're learning about these sort of growths and how these genes interact with each other. So it's coming still. Yeah.
I think there's a real danger as well. There's a number of children being labelled as having polycystic kidney disease that don't actually have polycystic kidney disease. Yeah. And it's actually very important, if you've been told that, to be absolutely certain to have that checked, because, as I say, radiologist, knowing a child has tuberous sclerosis, seeing cysts, they're almost always reporting those ultrasounds as probable polycystic kidney disease. And then actually when we look and we have it looked at, and in some cases we've actually had to resort to genetic testing, it's actually the epithelial disease. The problem is, and actually the geneticists have been really helpful about that, but we've seen a number of families who've been told for years their children have got polycystic kidney disease, and you're facing this future, and actually when you go through everything, it's a much more common type of disease. But as Murray says, you deal with a little part of your specialty, and they won't necessarily know that children get the simple cysts that are far more common in adults in this condition. So that's something to think about.
Can I ask you to go and stand next to Murray and share that microphone? Sorry. It worked for the neurologist, hopefully.
You hold it there.
Can I just add something really quickly? So the study you referred to around testing or trialling mTOR inhibitors on polycystic kidney disease was in polycystic kidney disease independent of tuberous sclerosis. Yeah. There's a theory that tuberous sclerosis acts as a bit of an accelerator on polycystic kidney disease. So there's some discussion about whether it's worth trialling mTOR inhibitors to at least take your foot off that accelerator, which may get you through to your 40s rather than your 20s, which is the case. I've been happy to talk about my sister, but so for the more severe cases, and then it might get you another 20 years. So those discussions are happening as to whether it's worth looking at that very small, so incredibly difficult and expensive trial to run, but finding a way to see whether for that very small population that might offer a bit of a window. But yeah, Tonya's point about making sure that what's been mentioned as lots of cysts equals polycystic kidney disease is actually an accurate statement, because
it's still a rare, it's a rare finding to have both conditions. Unfortunately, I will see a few because of my specialty, but the overwhelming majority of people with TS won't have polycystic kidney disease.
Sorry, I'm going to be a bit of a beginner on it. Particularly in my case, I have AMLs in both kidneys. One's at 22 centimetres and the other one at 17. So when you said about polycystic, I'm kind of thinking it might be a combination of both, or maybe just AMLs. But I've tried to fight the house system I've had 4 embolisations. The last one I went to, they said that the coil had fallen out. Is there any risk with that did fall out to travel throughout the body, or is it going to stay relatively close? Has it ever happened before?
Yeah, so AMLs, polycystic, both conditions can get really big. Coils and things like that, if you put an artificial object in one part of the body, it can move. And it can move down a blood vessel. It won't go along blood vessels and eventually come around and go back to the heart. type thing, but it can move through a blood vessel, migrate out of the blood vessel, and just sit beside the blood vessel. So if it's moved, it's unlikely, and I'll say unlikely, I won't say make promises of things, but unlikely to do any harm. But yeah, if people are having multiple embolization procedures, then I think, and this is all really just new in the last couple of years, people should be looking at special applications for things like everolimus through pharmac. And people can make a case for it, because whilst everolimus is really expensive, having all these procedures and the costs of that physically, emotional, financially to the hospital and the patient, the things actually start to even out. So it's something to think about.
I just had another question. Just recently, obviously going through Waikato, we've applied, like as you said, in NIPA, and it was originally getting information from Australia rather to back up, because they weren't even suggesting it to me. I tried for the, obviously, the everolimus versus the sirolimus, and I was more keen to go with the everolimus because of the size of my kidneys, but he said that it would have cost too much money to have my blood transported to Australia and back, but just reading your slide and said that it can be used in New Zealand, and you've got a child that is using it. Is she getting her blood work done in New Zealand? Or
So you mean the blood levels?
like the group, he said that all my stuff, like blood-wise, would have had to have gone back to Australia, the biosecurity problems and stuff, and he said try sirolimus instead because they were more comfortable and using that.
Yeah, when you use these drugs, they are challenging to use and they have to be monitored. You don't want to give too much. You obviously want to give enough to be effective. So we measure what we call drug levels. So you have to do a blood test and check that it's in what we call a therapeutic range. So my daughter has to have those tests done as well, and other people around who are on it for SIGAs will have those tests done. And I think now they go down to Christchurch. I'm not exactly 100% sure, because I try to stay well out of it and just let her paediatrician do it. I've got no slides of her scans and things because I'm petrified of looking up her results.
Go to Christchurch,
Yes,
Auckland,
yeah.
do both sirolimus and everolimus.
Yeah. What we have had trouble with is on the very first test we had done, all requested, beautifully written out on the form, and the result came back saying sirolimus level equals 0. And we're going, well, she's not on that. And they'd done so the people in the lab had read it wrongly, because sirolimus is used far more commonly for other conditions, and that's a regular request for a laboratory, whereas the everolimus was a rare request, and they just got it wrong. So then we had to go through it all again, which is disappointing when you're the parent of a child who's screaming down paediatrics while they have their blood tests. So,
Levels for both drugs can definitely be, they can definitely be done in New Zealand, Leah.
Okay, because I was just told that that was a dead-end situation.
But it might depend, I don't know the situation, the timing. It might be something that's more recent than when you last applied. I don't know.
Oh, it was just very recent, like within the last month. I had the information telling him, and he was, now I'm reading it up. And when he told me that, it's going to cost more money to take my blood out of the country to get it done and back, I was
they
like...
can be done in New Zealand now.
Okay, thank you.
But I understand the frustrations you have, because, like, even with specialties, in my specialty, I'm one of 6 adult nephrologists in Wellington. Most TS people in Wellington who have a tumour investigation will go to a urologist. They've got a lump on their kidney, they'll go to a urologist. And that's what GPs send them to. So we don't get them unless they're having an impact on their kidney function, or they come to us, if you like, by accident. So the numbers each individual doctor sees are still really low. And as I think it might have been Dave mentioned before, each doctor keeping up with the literature on these things, they just don't, because they can't keep up on every condition. But that's where you have to be an advocate for yourself. Unfortunately, it'd be nice if you didn't have to advocate for yourself, but until this is sort of splashed all over the headline news, that's what we're faced with each time. Yeah.
Hi, my name's Rochelle. I've got TS myself, and I've had 3 embolizations and a partial nephrectomy. And a skin specialist actually suggested that I go on rapamycin, not the topical treatment, but tablet form. And my renal specialist actually suggested that's a bad idea because of my kidneys are not fully functioning. But he didn't seem to know very much about it at all. So I'm just wondering if that's a... If you can confirm that would be...
So for every treatment, there's a downside. And there's side effects. And the mTOR inhibitors can cause harm to kidney function sometimes. So if kidney function is already past a certain point, we get nervous about using those treatments. So I think the epilepsy specialists were talking about having to weigh up risk versus benefit. And you have to say, well, hang on, if we use that drug but it's going to take away peripheral vision, that's okay if it's going to drop seizures from 20 a day down to 2 a day, even though you've caused harm by taking away some vision. So same thing in kidney disease. We might say, okay, well, the kidney function's poor. If we use this, there's a risk we'll make it worse. But if it's going to have this benefit, we have to weigh that up. And some of those questions are really, really hard to know because it's a bit of guesswork. And we don't know all the answers to those things, but are trying to weigh up how much benefit something will have versus how much harm it'll have as well. And you know, these are poisons. That's what I tell my patients when I put them on any drug. What are your poisons today? Because they all have side effects, and we have to be cognizant of that, even though they can have some great benefits as well. Sorry, David.
Yeah, but some poisons work better than other poisons. I think the point is that if you've got a child with a cognitive deficit or epilepsy, you're already, by the time those individuals are in adolescence or adulthood, you've been dealing and immersed in all that sort of thing. So the real issue is management of the kidneys in adults. And that's kind of, families are a bit overwhelmed by what's happening when the kids are younger. And then by the time they get older and they transition, then nobody really bothers with the kidney. And I couldn't compliment these guys more than actually how important it is to do really basic things to protect individuals for their lifetime. And if you don't start off at the beginning, then you're going to suffer later on.
Thanks, great to hear, because what we're seeing a lot here is kids who are getting their EEGs and seeing skin specialists but not getting renal ultrasounds. And say, I've seen about a dozen kids now, and they're going, one of them's gone over a decade, and one of them was the first imaging when they were 15, and they were known to paediatrics for a long time. So hoping, I've got a few ideas about how to try to get the renal side, because it's not the exciting side in childhood. It's not the side that's very visible, but it's the side that if you don't, and it's all very well to look at the charts and say, oh, but they're very unlikely to have it when they're a kid. Well, I know Sean's seeing a lot of stuff and we're seeing a lot of stuff, and I think probably there's a lot more going on quietly behind the scenes, but if you don't look, you don't know it's there. And if one of the issues for us for doing MPPA applications is you have to give an estimate of how prevalent the condition is in the country. We have nothing to go on in this country to start that. And the way funding of drugs tends to happen here, as Claire said, tends to be a few years behind Australia, gets through on PBS in Australia, then you find your MPPA applications start to get through is a bit slightly less hassle, and then slightly less hassle, and suddenly they're coming through on the same day, and then the next thing you know, you're matching to get things through on special authority, and there's a few year time lag between them, but it's very hard to even do an MPPA at the moment. Because it's just become a fallen out part of the screening process here.
So there are adults on mTOR inhibitors who's been on mTOR inhibitors for their kidneys for over 8 years now, in large numbers, which not part of trials, but part of the cohorts from the Cincinnati group and where John Bisler was, and now he's moved. And if you listen to John Bisler talk about, this, it's a no-brainer that. he wouldn't let anyone get to what you've just described because he would have already intervened. But you have to intervene. You have to be someone who's very knowledgeable about all facets of this, because it's not just stick somebody on a drug and that's it. You really do need someone who's going to look at all aspects of this, because sometimes an embolisation approach is going to be the right way, or a surgical approach for a single lesion which is accessible. So it's no question that people with TS at a young age and then through adulthood should really go and see somebody who actually is bothered to know about the disease, or ask somebody who is. And Sean now, I think, is being contacted by paediatric nephrologists and nephrologists, and that, and because he's done it, but everybody's upskilling and they'll do it. So there's no doubt, the guys in front of you will, are now those sort of individuals from New Zealand.
Thank you. Yeah, I just wanted to say thank you for explaining about the blood tests, and because I'm now thinking, oh, my GP's actually been quite onto it, because he sent me a blood test form, but I thought it was for the tegretol level, and I was like, I don't want to put Mac through a blood test for that when he doesn't need it. But now I'm thinking, oh, it's for the kidney function. That's really good. I'm sorry, Mac, but I'm going to follow that one up.
Our daughter's had her MRI scan June, and they spotted kidney lesions, so whatever you want to call them, but nothing else has been done. So should I be being her advocate and saying, actually, I need blood tests and I need that other thing?
Should we just shall I catch up with you at the break? Yeah.
Good work. Don't apologise. So
what I'm hoping to do is, I say, we can put these guidelines on the Starship clinical guidelines. That's easy. It's somebody putting up a link. The other thing that happens in New Zealand, which is a good area for getting people's attention, is the Paediatric Society meeting, which is in Wellington next year. I haven't told you this, and there's going to be a paediatric renal satellite day at Wellington Hospital, and so I was going to try and condense those guidelines into a New Zealand version, so not an MRI every 3 years, but an ultrasound. But this would be when to refer to nephrology, and things like that, and so that's already kind of planned for one of the sessions at that satellite day, which you can visit. And so sorry, but just trying to get this out, because everybody looks at those guidelines, because they're the guidelines used by paediatricians throughout the country. It's an A to Z guideline. It's publicised. Emails come out to all the paediatricians about the new guidelines on it every week. And there's people. It gets a lot of hits, and they track where the hits are coming from, and they can. It's good. That means that you can actually go out and go, but I know there's a guideline. Like, this is where you go, click on this. It's a guideline there. This is what, this is the simplified at a glance screening thing for kidneys. This is so it can become like your vaccination schedule. It's part of what you have in your, something, a tick box thing. So you don't have to think, and they don't have to think. But as I say, people have to know about it to look for it. And if they don't know there's a guideline to look for, they're not going to look.
Yeah, one thing I'd just add to that too, when we all get tests done, our kids get tests done, our other relatives or yourselves, and for every test that you get done, you should know the result. It's not the doctor's result, it's your result, and you should have that result. You should ask for a copy of it, or say when you get your scan done, okay, that's good, thanks very much. What does this mean now? What do I need to do about that result? And if the doctor or nurse or whoever you're seeing, psychologist, whoever, can't tell you what to do with that result, then the next question is, well, who can tell me what's next with that result? And if someone has a result and they're not telling you about it, that's wrong. And it's your information. You should know that information. and you've got the right for that person to deal with that information the right way. And if they don't know what to do with the information, then they should be ringing someone up and asking. And sometimes, Tonya and I will ring each other up about various things. Everyone's got a phone these days. It's very easy to make a 2-minute phone call to someone and say, oh, I've got this result, what's the story? And if they say you do this, this and this, then you can pass that information on. Someone could say, yeah, look, that's no problem at all. Just repeat it again in 3 years' time. It's not an issue at the moment. And then relay that back to you. So, I think if you do get tests done, you should know the result.
How do you know that they know what they're on about? Like that you're just said they don't like to make out that they don't know.
Yeah, and that's hard. That is hard, and I think we all have to deal with that difficulty. And sometimes it's a matter of just being comfortable with the information you've been given and feeling like, yeah, I feel like that's the right answer. And if you think, I don't feel comfortable that's the right answer, then someone else talked about getting a second opinion. And you're entitled to do that. And it might not need to be from a specialist. If you get given some information and you think, I'm not sure about that, even if you ask your GP, if it's from a paediatrician, say, they told me this, do you think that's right? Because at the end of the day, you've got to feel comfortable with the people that are treating you. And if you're not comfortable with that, then we have to work with that. And it's incumbent upon medical people. It's difficult for me because I have a hat on both sides. But we have to treat everyone with respect and tell them when we don't know things.
We don't own your child's information. They own that information. So we can't. People should have. You should have your own results. You should have copies. They should all be there. Somebody should be I go through an ultrasound result with families and tell them what the words mean. So.
And I think the question of how do we get to the point where we just know that the doctor that you're seeing knows what they're talking about, I think it's a multi-pronged thing. I think it's about establishing these guys as recognised, at least by us, as knowing what they're talking about. It's about equipping you guys with information. It's about things like Tonya said about getting the guidelines well publicised, because then we've got something concrete, as David said, that's evidence-based, that we can say this is what we do, and all of that feeds in the same direction. We could put all our eggs in one basket and say, right, we need to educate every health professional, but that's an ongoing thing. So we've got to, in a rare disease, you've got to take a couple of different approaches and hope we get to the point where we have better, best practice even, care for everyone.